We will be having 4 speakers today, so we will go through the presentations first, and then we'll have a longer section for Q&A at the end. So with that in mind, please do carry on introducing yourselves in the chat. It's nice to know who has joined. I would like to introduce our first speakers. Speaking first on this topic of cross-border collaboration and surveillance, we have Dr. Kasaya and Dr. Wajib from the Ghana National Malaria Control Program. Lizzie, I believe you're going to share your screen with the slides. If you could bring those up, please.
Allô, Anna? C'est que ce micro, nous avons côté, je pense. J'ai l'impression. À mon voice. Hello?
Hi, I keep hearing some sound from Bernard. Okay, do we have Wajib connected and Dr. Kazaya?
Yes, Wajib is here.
Great. We'll hand over to you, Wajib, for the first presentation. Thank you.
Okay, thank you very much. Merci, Anna. Merci, organisateur. Merci à tous. This is where my French ends. I want to thank you so much for your attention. I'll walk you through the cross-border collaboration and surveillance initiatives from the Ghana Malaria Elimination here. I'll be doing this jointly with Dr. Kezia Mam, the program manager of the Malaria Elimination Program, with the collaboration with the Port Health. Next slide. Okay, so this will be my presentation outline. We can move to the next slide as we don't have much time. Okay, the mandate of the Malaria Elimination Program is to lead all malaria elimination effort in the country, coordinating all agencies and partners in the fight against malaria in Ghana. The mission is to ensure that the entire population has access to preventive and curative interventions to achieve the mandate. Our vision is a malaria-free Ghana to ensure we have socio-economic development. Next slide. This is how far we came, coming from the 2012 baseline that we set for ourselves. The reduction of malaria mortality in all ages of about 96% from 2012, from 10.9 or almost 11 per 1,000 cases, per 1,000 deaths that we have seen, to less than 1, or let me say 1 malaria death per 1,000 population in 2022. Reduced malaria morbidity about 44% from the 277 per 1,000 population to 155. We have actually improved diagnostics for malaria, almost over 150%, from 38% in 2012 to 98% in 2022. However, malaria remains a public health problem in Ghana, with about 10 million suspected malaria cases in 2022, and about 5.2 of these 10 million cases confirmed. The admissions were over 400,000, and we have about over 150 deaths reported in 2022. Next slide. So in terms of the prevalence of malaria in Ghana, from an average of 27.5% in 2011 to a current 8.6% in 2022, as a last year DHS report, with regional variations. The good news is that you could see the colors becoming lighter across the years. And Greater Accra remained the lowest, and I want you to concentrate on that, because Greater Accra remained the lowest over the years, with an average of 2% across. Now, this is the prevalence of malaria in the country, just as part of the update. Can we move to the next slide, please? Right. So towards the midterm evaluation of the 2021-2025 malaria strategic plan in Ghana, we actually did a malaria risk assessment of the district, of the burden of malaria across districts. Now, the risk assessments considered three variables: parasite prevalence across the districts, malaria incidence across the districts, and then all-cause mortality across the districts. Now, these three variables were put together to come up with the risk map as we're seeing now. Based on this risk map and the attempt to move towards elimination, the malaria elimination assessment 2 was equally completed to look at how do we get to elimination? Where are we now? What system do we have in place? Surveillance or otherwise? And what we see from the map is that we have about 21 districts that are very low, considered very low, 8 districts low, about 83 moderate, and 149 of the 261 high. The next slide. Now, based on this, the strategic plan for 2024-2028, which will be implemented from next year and launched very soon, considered a number of things. The goal is to reduce malaria mortality with 2022 as the baseline, reduce malaria case incidence by 50% by 2028, and to eliminate malaria in the 21 districts with a very low malaria burden, as we just saw in the slides preceding this one. Next slide. Next slide, please. Okay. These are some interventions, new interventions that the malaria elimination program in Ghana is looking to add towards the drive to elimination. We have implemented the key interventions that we already know: the mass campaigns, the IRS in targeted areas, seasonal malaria chemo prevention, IPTP across the nation, case management with testing, limited larvicidin and malaria vaccine currently in about 95 districts. But to move towards elimination, these are the key and new interventions that have been proposed in the 2024-2028 Malaria Elimination Strategic Plan. Intermittent preventive treatment of malaria in school children, post-discharge malaria chemo prevention, and mass drug administration. We're looking at post-discharge malaria chemo prevention, which is use of long-acting anti-malaria given after people who are discharged for positive malaria admissions. The IPTSC is actually for areas with a very consistently high malaria prevalence. And we're looking at mass drug administration for every eligible person within the area that is eligible for this intervention, regardless of whether they have malaria or not. We're also considering some case management interventions with a single dose primaquine for gametocyte clearance and transmission blocking, patient follow-up and retesting for cure, and enhanced diagnostic capacity. We're also looking at introducing something new for the surveillance system. Next slide. We're looking at enhancing our surveillance by bringing on board the pharmacies and OTCMS, the over-the-counter medicine sellers. We realized that quite a number of cases actually visit these outlets before coming to the health facility, or they don't even come to the health facility when they're cured. But the data in those systems are actually lost to the surveillance system. We're looking at actually moving into comprehensive case-based reporting, particularly in the 21 districts for the elimination, and then scaling up to the rest of the country. We're also looking into case and foci investigation and response in the areas that are moved into elimination. And then, for the reason why we're here, the cross-border malaria surveillance is one of the things that we highlight in the 2024-2028 NSP. Next slide. The malaria surveillance system. Next slide. So currently, the malaria surveillance is actually integrated with the HMIS system for the health sector, where we have facilities, private, public, quasi-government mission, including the community chips here, which is seen by the red area below, are all reporting into the HMIS system. Malaria is reported here, including the teaching hospitals, which is actually the tertiary level. Some of the facilities are reporting using paper-based registers, while others are using the electronic transactional systems. All these reports feed directly into the DHIS system through the various transactional systems. But for the paper-based system, some enter into the DIM system directly, while others submit it to the district level for the data to be entered. And after district level, there's no more data entry. Let's move to the next surveillance system. Next slide. Now, what I described to you in the previous slide is about these areas that you are seeing down here. So from the community to the hospitals, the health centers, the chips, the private facilities, all those information enters into the District Health Information Management System, which is the HMIS system for Ghana Health Service or the Ministry of Health. And all malaria routine data is in here. However, we have other health information systems that we use, which is, for instance, the SICAP, which is the system we use for the seasonal malaria chemo prevention, the nets for schools, for net distribution in schools, the net app for the mass campaigns, those ones you see here, the LSM apps, and the TES, therapeutic efficacy studies systems, and the GILMIS, that's the Ghana Logistic Management Information Systems. All these other ones are also feeding into what we call the malaria data set, which is currently sitting in the DHIS system. The idea was to have a malaria repository away from the system, but now we have it embedded into the DHIS system. So this is an overview of the surveillance system that we run in Ghana. Now let's move to the next slide. What is currently available for cross-border surveillance? Next slide, please. So Ghana is bordering 3 countries. So we have Burkina to the north, we have Cote d'Ivoire to the west, then you have Togo, and all these countries are actually, there are about several districts, there's about 40 districts that border all these 3 countries, as you can see from the map that you're showing on your slide. So these are the areas people can enter into this country, most of this by road. We also have the ports, that is the harbors in the western region, and then we have the airports where international also enter. The airport is actually located somewhere down here in Greater Accra region. Okay, the next slide. Now, Ghana has a number of collaborations with its neighbors. In fact, in 2015, Ghana, Burkina, Togo signed a pact to strengthen the relationship between these countries. And one of the things the key things put in that pact in 2015 was to look at cross-collaboration for education, health, and agriculture. Prior to that, there has been the collaborations for the military, for immigration, among other issues, other things. But in that pact, the concentration was education, health, and agriculture. Now, the next slide will try to tell us how far we have done in the implementation of this and how it relates to malaria surveillance across the board. Next slide. So our cross-border collaboration, the health sector, there is an agency or department in the Ghana Health Service responsible for port health, and they're actually responsible for all border activities with respect to health in the land, sea, and the air points of entries and exits. And they do this in partnership with several agencies, the Ghana Immigration Service, the revenue authorities, the military, the customs, the ports and harbor authorities, the police, the veterinary services, and all these agencies, the avians and other ground handlers. These are the people they collaborate with to implement this. Now, let's look at what the current port health system looks like. Next slide. So typically, travelers are screened for any form of disease as we capture in our IDSR. If a case is suspected, the required case investigation form is filled, and that case is actually handled according to some later procedures. Well, there's only a basic clinical support at the borders, and the subsequent actions are sent to the various institutions that are responsible for this. Now, of interest to the topic that we have today is that the current reporting system for the port health is actually a paper-based report. The routine cross-border meetings are very minimal. However, if they detect any case, they notify each other. I mean, if I say each other, if Ghana detects any case, they notify the border, the next country, using the international health regulation guidelines that was developed in 2005. We tried to look at these issues whilst we were looking into the 2024-2028 malaria strategic plan as we move towards elimination. And the next slide will show you some of the SWOT we came up with, which led to the innovations that we're going to discuss. So the strength, we have a port health department which is responsible for entry and exit, which is right under the Ghana Health Service where the malaria elimination program also belongs. We have a reporting system in place for screening travelers, temperatures and other vitals are taken, and very few other key health checks are made. We have some minimal engagement with the neighboring countries. Now, I'll take it one after the other. So the port health department in itself, one of the weakness we noticed was that they have inadequate port health staff, even where they operate. No port health staff for some approved points of entries, and there are no staff at the unapproved borders. We have inadequate logistics for surveillance for the port health. The in-country political will is actually available. Now we have ECOWAS, which is trying to actually bring us together, not just for the military and other things, but even for health. And WAHU is actually trying the best they can to do that. Baby steps yet, but we're looking forward to taking the opportunity of this to expand the collaboration. In fact, in the recent seasonal malaria chemo prevention in the northern regions, if you look at the map I showed you, Ghana, Burkina, Togo tried to plan the SMC together so that they do it in time, because people move from Ghana to Burkina and to Togo during the seasons. And so something has started there, but like I said, still baby steps. In terms of the reporting system, the weakness was that there was no electronic system in place for cross-border. The port health data is also not integrated to the general HMIS system, and the screening does not include malaria. The electronic national HMIS system is available, very robust, that can be integrated with the port health, and we're seeing this as an opportunity to build that. In terms of the engagement with the neighboring countries, the meetings are infrequent and not something that seems to be very structured. The existing cross-border collaboration that we have established during the SMC and what exists with the immigration for other reasons are actually opportunities we can look at to expand. But the threat we foresee is political instability and insurgencies, importation and exportation of infectious pathogens to and from neighboring countries, inadequate funding, and the threat of terrorism. These are threats we looked at. So what are the interventions or innovations we looked at or we're looking into bringing in to strengthen this? Next slide. So we're looking at strengthening the collaboration between NMEP and the port health. In fact, the NSP development involved the port health from the start, because when you begin elimination, then cross-border issues become very sensitive. So we've already started the engagement, and they were involved in the development. As a matter of fact, they are involved in the presentation, in the preparation of this presentation, and I think the head of the port health should be on this call to answer some questions if there are. We're looking at establishing a transactional electronic surveillance system for port health, interoperable with the HMIS system. And also, if possible, we'll see how we can automate the cross-border surveillance. We're looking at integrating the port health with our system, and we're looking at a strong vector surveillance system across the countries. We're also looking at advocating for the infrastructure of the port health to improve, because indeed, if that improves, then we can maximize the usefulness with all the initiatives that we're thinking of doing. We're looking at capacity building for the port health staff, not just for the general port health, but also for malaria elimination and how the surveillance system can serve the drive towards our elimination agenda. We're looking at to highlight the cross-border surveillance as part of the current engagement we're doing with the countries that we started with, and getting the port health involved and trying to make sure that we're able to institutionalize the surveillance system. So any assistance, any help for Wahoo, in fact, this meeting was timely as we are moving forward to launch the 2024-2028 NSP. We are glad we have this platform to share this so that anybody has any lessons, experiences, and support that we can be given to strengthen and build this cross-surveillance system. We'll be very happy to get this. The next slide. I would like to acknowledge Dr. Lawrence Latte, the National Coordinator for Port Health, who helped us, who is actually with us and helped put this presentation together with his data manager, Mrs. Magdalene Seya, for the collaboration that we've already started and for their input into the malaria elimination agenda, to the M&E plan and the surveillance system structure. Thank you very much. The next slide is just an acknowledgement. And thank everybody. Thank you all for your attention. Merci beaucoup. Dr. Mam is here. Dr. Latte is on call. If you have any questions, they will all join us to answer. Thank you.
Thank you so much, Wajib. I believe Medoun is on, so I'd like to hand over to him if possible. Medoun, are you on?
Allô?
Hi, Medoun, we
Allô,
can
oui.
hear you. Oui.
Bonjour, comment vous allez? Excusez-moi, j'avais des soucis de connexion avec ma machine, mais là, je suis connecté avec le lien de là-dessous. Donc, je ne vais pas trop vous retenir. Merci pour le présentateur qui vient de finir pour le Ghana. Si on peut passer, Lizzie, au présentateur suivant. Allô?
Yes, we hear you very well now, Medoun. Thank you.
Thank you.
Hello, my name is John Chimumbwa. I run the Secretariat for Southern Africa Malaria Elimination Initiative. Bonjour tout le monde, Madame et Messieurs. My speaking will be to introduce the speaker for the Elimination 8. Now, the full name for this organization is called Southern Africa Development Community Malaria Elimination Aid Initiative, which is shortened to just E8. So the E8 is based on the Southern Africa Economic Bloc, the one in short called SADC. SADC comprises 16 countries. Most of those, malaria is endemic, but there are a few which do not have malaria. So the total number of countries in the bloc is 16, and 8 out of those 16, for those who would understand Southern Africa, Angola, Botswana, Eswatini, Mozambique, Namibia, South Africa, Zambia, and Zimbabwe. In 2009, these 8 countries came together on the basis of the simple principles of malaria is completely preventable and treatable. Malaria has economic impact on the development of the region, meaning malaria causes poverty and poverty causes malaria. The countries in this region have tried, some of them for over 50 years, trying to get rid of malaria. And they all came to the realization that as long as countries are geographically interconnected, it is not possible for one of those countries to eliminate malaria while the neighbors have malaria. And so, on the basis of that principle, in 2009, the ministers of health and those responsible for HIV/AIDS and approved the creation of the SADC Malaria Elimination Aid Ministerial Subcommittee to function as a subcommittee of the SADC ministers to focus on malaria elimination. And to do this, they created a permanent secretariat to support the decisions of the ministers to work around the clock to eliminate malaria from the E8 countries in the shortest possible time. After this decision in 2009, the coordination work was put into full gear and was given 5 pillars to focus on. And these are important, dear listeners. When I complete this, I'll tell you where today's topic about cross-border collaboration and surveillance fits into this mandate. The first thing was to coordinate the regional collaboration to achieve zero malaria transmission by 2030. You realize that in an international sense, collaboration of more than one country cannot happen without a mandate. So none of the member states, however good they are, can be able to call other member states to do what a country wants. So they have to have an agreed mechanism, in this case, under the auspices of the SADC subgroup to focus on malaria. To advocate and elevate and maintain malaria at the highest level, meaning on an annual basis, the ministers have to get a report on the progress that's being made towards elimination as they go. To harmonize policies, working together, starting together, ensuring that every neighbor protects the next neighbor so that malaria is not moving from their side of the border to the other side. To engage and facilitate cross-border transmission, there is a lot of work that has been done in that area, and then to sustain resource mobilization efforts to make sure that there is always resources for the region to fight malaria. And so the issue of surveillance and the data management falls under the pillar of policy harmonization, knowledge management, and data sharing across the region. And this is the pillar under which we, as the Secretariat, are able to work with the member states to share information and data and make decisions that are regional-wide on the basis of what we see on an annual basis. Cross-border surveillance is not just something that is done by the Secretariat. There are a number of other partners that are participating or carrying out some work in this region on the cross-border interface, on the realization that we need to deal with the cross-border to ensure that as the countries are working hard towards the elimination within their borders, the cross-border is taken care of by this regional mechanism. And I think to give you more information, I'll hand over to the main presenter for the SADC Malaria Elimination 8 initiative on behalf of the 8 member states that I have. Okay, maybe that's a cue that I should stop talking. Let me introduce my colleague. Bongani Dlamini is the officer in charge of cross-border work at the SADC Malaria Elimination 8 Secretariat. And he is a seasoned surveillance manager and oversees all matters of the epidemiology on the cross-border interface. We do have a number of channels and mechanisms through which data is shared at the regional level, and how we turn that data into decision-making for the region all the way from the sub-district level to the heads of state, and how the data flows around. I'll introduce Mr. Dlamini now.
Ok, merci. Donc, on attend votre collègue, s'il vous plaît. Il nous reste une dizaine de minutes pour cette présentation.
Thank you so much. We will move hastily. And like John said, the topic, and greetings to everyone, by the way, the topic discussed today resonates with us. I won't touch a lot on the background and what the SADC E8 looks like and how it is structured. So next slide. Again, next slide, to discuss a little bit on what John was saying about how we get our mandate from the heads of state, which all 16 of them signed to eliminate or declared that we should do away with malaria by 2030 in the SADC region. Next slide. Again, I won't spend too much time here on the mandate and the areas of work and our objectives. All 5 of them have been discussed. Next slide. Generally, the idea, as you see the maps, the 3 maps of Southern Africa, specifically the E8 sub-region, was that in 2018, those countries which were in elimination would move forward such that by 2021, some of them, be it Botswana, Eswatini, and South Africa, would have eliminated. And by 2025, we'll see that all those which are the southernmost countries, Namibia, Botswana, Eswatini, and South Africa, would now be at a position where they are preventing reintroduction, and that the neighboring states in the north, Angola, Zambia, Zimbabwe, and Mozambique, would, at a subnational level, by 2025, would have transitioned some of their districts to elimination and others preventing the re-establishment. Next slide. However, it has not necessarily taken that shape from the previous slide. We do see that transmission is still occurring in the frontline countries, as we call them, the southernmost countries that are in elimination. And we see that there are some outbreak years, like in 2017, where we saw a spike in cases in almost all the frontline countries, South Africa, Namibia, leading in the case numbers in 2017, however, stabilizing towards 2020, 21, and 22. However, we do see that countries such as Botswana, Eswatini, have seen very low case numbers in as far as malaria is concerned, thus still maintaining their elimination agenda. Next slide. As I've mentioned, that the situation is still critical in the region. Reason being that there is quite a lot of population movement from our northern neighbors all the way to our big city centers and our neighboring districts. There is, as our previous speaker mentioned, that there is porous borders with neighboring countries, and they encouraged trade between countries. So we do see importation of cases into eliminating districts and zones, which fuels transmission in elimination settings, such as our frontline countries from our second line countries, as I've mentioned. Next slide. Just to highlight on the tools that we have employed for regional surveillance. If you go to the next slide, you'll see that we'll just go a little bit quicker just to highlight how we share data. This slide shows how we have actually been trying to improve in data sharing through emailing Excel sheets to countries and selecting those border districts, 89 of them in total, to share data, be it on confirmed cases, those reported local, and those and mortalities. This is one way of data sharing. However, there are areas of improvement, but on a month-to-month basis, we do receive data from all countries, and on a quarterly basis, then compile reports as to how the border districts fare. Next slide. Again, through the sharing of the data, we're able to map the incidence of malaria across border districts of the E8 and see that there's still fueling of transmission from our northern neighbors, as we see lower transmission in parts of South Africa, Eswatini, Botswana, and some parts of Namibia. But we do see that neighboring states such as Mozambique, Angola in the north, Zambia, and Zimbabwe still do contribute to the importation of cases in eliminating zones. Next slide. Furthermore, with this data, we're able to deploy interventions in key areas where we see that there is increase in transmission in specific areas through the collaboration with programs to actually not necessarily to take over the work of programs, but to chip in because we are aware that resources are quite thin. So the regional instance is also able to provide some resources and interventions at the cross-border interface. Next slide. Again, this is another tool that we use, which we call the situation room. These are meetings, monthly Zoom calls where we come together as countries and partners, where we discuss the situation on a month-to-month basis, specifically as malaria is seasonal in the region. you do find that IRS campaigns will start between October, November, and we see how we prepare for those campaigns. And where outbreaks occur, we also do monitor outbreaks, and we respond as such, and we elevate the request of countries to technical committees and permanent secretaries for unlocking resources to respond to outbreaks. And I will emphasize also that partners also provide resources, be it the RBM partnership, be it WHO, ALMA, to actually respond and mitigate epidemics as they occur. Next slide. This is an example of a template that we use for our discussions. So countries will update on a month-to-month basis the case numbers, as it were, mortality and investigations. Some countries may not necessarily have transitioned to case-based surveillance, and they don't do investigations. So you see that. Next slide. Very critical also in the situation room, we do discuss commodities, where we also capture where they are in as far as stockouts are concerned, and their projections and the numbers of doses till December, or however the position would be in the year. And also understanding which institutions also support the procurement of resources and the delivery of these commodities on the ground. So this is also worthwhile information, and just to underscore that this tool is adapted from the RBM commodity tracker, which we also use for countries, and we do not duplicate efforts as such. Next slide. So this is just a summary on the situation room that we're able to monitor trends on a month-to-month. This is 2022 trends, as it were, just to show that we are aware of the trends year on year, and we can compare them previous years and months to actually plan accordingly as a region. Next slide. This is also one clever tool that we adopted and adapted from other partners of ours, and it is really quite a good tool to show where you're making progress and where you are struggling, be it in areas such as epidemiology, be it vector control financing and other policies. So it is a traffic light kind of approach where countries also provide insights as to where they are in as far as the different areas of work or interventions, as it were. It is a key advocacy tool for the region because ministers and heads of state would be able to see progress towards elimination using the scorecard. So I would have spent much more time on the scorecard. However, we move on to the next slide. With the scorecard, again, we're able to tell the story of malaria in the region, which countries compared to another, and those that share a border, how they are actually faring in as far as transmission is concerned. So I won't spend too much time on this one again. Next slide. Another tool that we employed at the beginning of at the start of interventions through support from the Global Fund, we deployed border health posts in key transit routes in the region, formal and informal, where we deployed container-like facilities at border crossings and working with port health, and also sometimes working with the military in informal crossings where we are able to test, treat, and also refer as guided by policies in different countries, where we refer also to nearby facilities for treatment. And those that are in transit, we also encourage them to visit their nearest facility. As you are aware that majority of traveling or mobile migrant populations would be going to non-endemic big cities, be it Johannesburg, Windhoek, as it were. Next slide. I won't spend too much time as to how the border health posts, because they now were handed over to countries due to dwindling resources and investment in this one. However, countries have taken them up and they are now integrated as facilities in countries. So we're happy about that, working with Port Health and utilizing them fully. Next slide. Again, as a last tool, we do also have reports as you came to understand how the E8 within SADC is structured. We do feed into the bigger SADC malaria report. However, we also produce annual reports, as it were. Please do peruse through our 2022 annual report. Next slide. Next slide. Some of our innovations that we thought of, some gained traction, some did not. The regional surveillance bulletin, quarterly we produce a bulletin. This gained traction and it provides a good picture of what is happening in the region. Online platforms, web-based tools where we are just tracking districts as to the status of outbreak, you know, the sensitivities of data sharing and information sharing, some countries, and finally, the region, so that this may not necessarily work best if it's not linked into their databases, because it is basically self-reporting and it needs to be vetted by programs themselves. So it did not necessarily gain much traction, but it is one way. If ECOWAS also would adapt it, we're happy to share the concept and the tools that we employed. Next slide. Cross-border committees, I did pick up also from the previous speaker that most of the time they are not necessarily clearly understanding the terms of reference and they're not frequent that much, but we have seen how the E8 has played the central role in actually providing these cross-border committees resources and the tools they need to actually perform and talk to each other. Sometimes it takes WhatsApp group just to have a cross-border committee. Next slide. I won't spend too much time on this one, but this is one way of subnational elimination approach. Please do visit WHO guidance on elimination on subnational verification. These are districts that reach zero, whereby we say we have to hold them at zero by providing resources for prevention of reintroduction. We award them for the great work that they've done. Ministers come together annually and look at those districts that have reached zero and are awarded and supported to prevent reintroduction. Next slide. Next slide. In summary, just to buttress a few points, as we are talking about data in action, we have seen that there's border district data. It's shared monthly and it helps us in epidemic preparedness and response. We also have situation rooms where we come together as countries and we share what we do and where we are facing challenges. We also have quarterly surveillance bulletins, as I've said. It's sparked interest because it also gives an insight as to what one country is facing, forecasting, and also sharing such information. The scorecard, very high level engagement and advocacy tool, which we use to engage our policymakers for policy decision and unlocking resources. Border health post, we target mobile and migrant populations, as it were, as they cross between our countries. And lastly, subnational verification, like I mentioned, do visit the WHO guidance on how best to adopt this approach in country at a subnational level to track elimination at district level. This should be my last slide. Colleagues, thank you very much for your attention. Over.
Alors, merci beaucoup. Merci pour cette brillante présentation. Je pense que on vient de voir une autre forme de gestion transfrontalière du paludisme qui a la particularité d'être portée par une organisation sous-régionale et qui implique plusieurs pays. Donc ça aussi, c'est une autre forme de collaboration transfrontalière basée essentiellement sur la surveillance et la prise de décision qui est transmise aux différents pays. C'est une excellente présentation. On va passer à un autre exemple de collaboration transfrontalière. Donc, on va suivre la présentation de Latsou Diouf du Programme national de lutte contre le paludisme du Sénégal. Là, vous pouvez charger votre présentation.
C'est Anna qui s'en charge, je crois.
Anna, vous pouvez mettre la présentation de Latsou.
Pas encore.
Yeah, that's over to Lizzie, actually. Lizzie.
Lizzie? Lizzie?
Voilà, merci Lizzie. Bonjour à tout le monde. J'ai donc le plaisir de partager avec vous les quelques expériences du Sénégal en matière de collaboration transfrontalière, principalement avec la Gambie, une république voisine, donc avec laquelle nous avons eu à mener beaucoup d'expériences en matière de lutte transfrontalière contre le paludisme. Diapo, s'il vous plaît. Alors, le plan de présentation que je vous propose est le suivant. On va passer rapidement là-dessus. Lizzie, diapo. Slide, please. Thank you. Alors, donc, voilà le plan de présentation que nous vous proposons. Nous allons particulièrement insister sur le cadre juridique, donc, qui a un peu établi la coopération frontalière avec la Gambie. Nous allons ensuite parler des expériences de synchronisation que nous avons eues avec la Gambie, principalement en 2019 et en 2022. Nous allons ensuite parler de la surveillance du paludisme en zone transfrontalière à travers deux exemples. Et enfin, nous allons terminer par dégager quelques perspectives de collaboration avec d'autres pays. Slide. Alors, ce qu'il faut comprendre, c'est que le Sénégal et la Gambie partagent une frontière commune qui est longue de 740 km, comme vous le voyez ici sur la carte. Et cette zone frontalière, donc, comporte du côté sénégalais 7 régions, sénégalaises donc, 6 régions gambiennes. Nous avons toujours, au niveau du tracé frontalier, 75 postes de santé sénégalais et 84 postes de santé gambiens. Alors, du côté gambien, nous avons 1454 villages qui sont établis tout au long de la frontière et 350 villages sénégalais. Et comme vous le voyez ici, en termes imagés, le Sénégal est comme la tête d'un lion et la Gambie, c'est comme donc un doigt qui est enfoncé dans la bouche de ce lion-là. Et vous le voyez ici sur la carte qui est présente. Et nous avons au Sénégal et en Gambie 2 langues qui sont parlées de façon officielle, à savoir donc le français et l'anglais. Mais nous avons à côté de ces 2 langues plusieurs langues locales qui sont parlées comme le Wolof, le Pulaar, etc. Donc les 2 peuples partagent. Slide. Alors, notre collaboration transfrontalière avec la Gambie, merci. Donc, nous avons des dates charnières. Alors, la première date, donc, qui a entamé le processus de la collaboration transfrontalière, revenez en arrière, s'il vous plaît. Donc, la première date, c'est 2018. Donc, 2018 a vu la signature du mémorandum d'entente.
So we had a big signing of a mandate in which was the MOU. So here we have. So in 2018, Senegal and Gambia they signed a memorandum, and in this memorandum, we
politique et juridique
estabelece o quadro jurídico.
Donc c'est ce mémorandum qui nous a permis après en 2019 de dérouler la première campagne de distribution de moustiquaires, une campagne synchronisée de bout en bout. Il y a ensuite 2020. En 2020, nous avons organisé, là aussi nous allons y revenir, nous avons organisé la PECADOM frontalière. En 2021, il y a eu le partage des procédures opérationnelles normalisées et le partage également des outils de collecte pour la surveillance et la riposte. Et enfin, en 2022, nous avons réédité l'expérience de 2019, à savoir donc l'organisation synchronisée de la campagne de distribution de moustiquaires. Slide. Et nous continuons donc à entretenir d'excellentes relations en matière de collaboration transfrontalière. Pour revenir un peu sur le cadre politique et légal, slide. Slide, Lizzie. Slide. Alors, ici, nous avons le pont qui relie le Sénégal et la Gambie. Voilà, donc, voilà la signature donc, du mémorandum d'entente, un document qui a été paraphé par les deux ministres de la Santé, à savoir le ministre de la Santé du Sénégal et celui de la Gambie. Non, revenez en arrière, s'il vous plaît. S'il vous plaît, slide précédent. Voilà. Donc, les deux parties, principalement les deux ministres, se sont engagés donc à promouvoir et à mettre en œuvre une coopération technique. Et cette coopération technique est dénommée Initiative sénégambienne contre le paludisme au niveau des régions frontalières. Alors, cette initiative prend en charge trois domaines principalement. Il y a d'abord le domaine de la distribution des moustiquaires, qui nous a donc permis d'organiser deux campagnes synchronisées de distribution de moustiquaires. Il y a le domaine des aspersions intradomiciliaires, donc, qui a été également mis en branle dans le cadre de cette coopération. Il y a le domaine de la surveillance communautaire, celui du partage des expériences et celui également du partage des données. Mais tout cela est sous-tendu par 11 engagements. Slide. Et nous avons ces 11 engagements-là qui sont déclinés ici. Slide, please. Et nous allons insister sur quelques engagements seulement. Le premier sur lequel nous allons insister, c'est la mobilisation des ressources. Parce que, comme vous le savez, une collaboration transfrontalière requiert d'énormes ressources. Donc, la mobilisation des ressources, elle est importante. C'est d'ailleurs la raison pour laquelle, pour les deux campagnes que nous avons eu à organiser ensemble, slide, le Fonds mondial donc, est largement intervenu. Il y a également d'autres partenaires comme l'USAID, PMI-USAID. Toujours dans le cadre de cette coopération transfrontalière, CRS également est intervenu, Catholic Relief Services, donc qui nous ont aidés à rendre disponibles beaucoup de ressources, donc qui nous ont permis d'implémenter les stratégies. Slide. Slide, Lizzie. Slide, please. Lizzie. OK, apparemment, Lizzie a des problèmes avec les diapositives. Voilà. Alors, comme je le disais tout à l'heure, donc la mobilisation des ressources, elle est fondamentale. C'est les 11 engagements donc, que nous avons pris de commun accord avec la Gambie. Donc, il y a la mobilisation des ressources, mais il y a un point important. Il s'agit de l'identification des points focaux. Au niveau de chaque pays, il y a un point focal qui se charge de la collaboration transfrontalière, ce qui nous permet un peu d'huiler les relations entre les deux pays et de trouver des solutions à tous les problèmes auxquels nous sommes confrontés. Il y a également comme autre engagement pris par les deux pays, la coordination et la coopération à tous les niveaux. Slide. Alors, nous allons maintenant passer, slide s'il vous plaît, Lizzie, à la synchronisation donc, des campagnes de distribution. Comme je l'ai dit tantôt, nous avons organisé ensemble deux campagnes principalement. Slide. La première campagne, donc, c'est celle de 2019, donc une campagne synchronisée de distribution de moustiquaires. Ce fut la première expérience de collaboration transfrontalière entre nos deux pays. Et lors de cette campagne, comme je l'ai dit tantôt, il y a une forte synchronisation de tout le processus d'ailleurs donc de distribution de ces moustiquaires. Et cette synchronisation a été sous-tendue, bien entendu, par l'initiative sénégambienne de lutte transfrontalière contre le paludisme, initiative fortement appuyée par le Fonds mondial. Slide. Et ce qu'il faut comprendre ici, c'est que les villages, aussi bien sénégalais que gambiens, ont été donc les cibles de cette activité principale. Et de la planification à la coordination, donc tout a été synchronisé. Et dans le détail, nous avons ici les activités donc, qui ont été synchronisées avec la République de Gambie. Donc, la communication, tous les messages distillés donc, au niveau, donc, pendant cette campagne ont été harmonisés. Donc, nous avons eu à organiser des ateliers d'harmonisation des messages entre le Sénégal et la Gambie pour un peu harmoniser donc, tous ces messages donc, liés à la campagne de distribution des moustiquaires. Donc, les messages qui étaient destinés aux populations sénégalaises étaient similaires à ceux qui étaient donc destinés aux populations gambiennes. Le recensement et la distribution étaient également des moments forts de synchronisation. Et donc, aussi bien au Sénégal qu'en Gambie, les mêmes dates donc, ont vu, n'est-ce pas, le déploiement des équipes de volontaires donc, qui ont fait le recensement des populations, qui ont procédé à la distribution des moustiquaires. Il y a aussi ce qu'on appelle les rencontres entre vis-à-vis. Donc, au niveau opérationnel comme au niveau central, il y a eu des rencontres périodiques entre les différents acteurs, n'est-ce pas, pour un peu anticiper sur les problèmes qui pouvaient survenir et essayer de trouver des solutions par rapport à ces difficultés-là. Il y a également la supervision conjointe. Donc, nous avons, comme son nom l'indique, que ces supervisions, nous les avons menées, n'est-ce pas, de façon conjointe. Donc, Sénégalais et Gambiens ont supervisé la campagne de bout en bout, aussi bien lors du recensement que lors de la distribution. Les évaluations ont été également faites au niveau opérationnel comme au niveau central. Slide. Et comme vous le voyez ici sur ces images, donc tous les acteurs sont intervenus dans le processus, n'est-ce pas, de synchronisation. Diapo. Alors, ici, donc après cette diapo, voilà, donc pour vous dire donc effectivement, beaucoup d'acteurs sont intervenus dans ce processus de synchronisation ici. C'est une cartographie qui a été mise à la disposition des deux pays par l'USAID. Donc, dans cette cartographie, nous avons pu identifier tous les postes de santé gambiens et sénégalais. Comme vous le voyez ici, les postes de santé gambiens sont en bleu, les postes de santé sénégalais sont en rouge. Et vous avez le tracé frontalier et les villages ont été identifiés, ce qui a beaucoup facilité la progression des équipes lors de cette campagne de 2019. Slide. Et cette campagne de 2019, nous avons pu donc présenter les résultats, comme vous le voyez ici sur ce abstract. Nous avons pu présenter en 2020 les résultats lors du congrès AST Match, donc tenu aux États-Unis. Slide. Lizzie, vous êtes là? Voilà. Voilà. Donc, ce slide-là, donc, c'est juste un abstract donc, qui a été présenté lors du congrès de 2020 aux États-Unis, congrès AST Match, qui retrace un peu tout le processus donc, que nous avons emprunté lors de cette campagne synchronisée et les résultats qui ont été obtenus. Des résultats très satisfaisants en matière donc, de collaboration transfrontalière. Slide. Alors, nous avons voulu également vous présenter quelques images qui montrent un peu l'intérêt de l'implication de tous les acteurs à tous les niveaux pour une bonne réussite d'une activité, n'est-ce pas, de synchronisation, de collaboration transfrontalière. Ici, en haut, vous avez une réunion sur la cartographie qui a regroupé toutes les autorités. Quand on parle d'autorités, on fait référence aux autorités administratives, aux autorités policières, aux autorités douanières, parce que nous sommes sur les frontières. Et tous ces acteurs-là interviennent dans le processus. Donc, il est important de les impliquer, de renforcer cette implication de tous les acteurs donc, dans le processus de synchronisation et de collaboration transfrontalière. Ici, vous avez les coordonnateurs des deux programmes et les gouverneurs et les autorités policières et douanières de la Gambie et du Sénégal. Ici, en bas, vous avez donc une réunion qui s'est tenue à Banjul, qui portait sur l'harmonisation des messages, comme je vous l'ai dit tantôt. Donc, tous les messages étaient communs, aussi bien au Sénégal qu'en Gambie. La seule différence, c'est qu'en Gambie, c'était en anglais, et au Sénégal, c'était en français. Diapo. Alors, nous allons passer à la deuxième expérience en matière de distribution de moustiquaires. C'est la campagne de 2022, donc, que nous avons récemment organisée. Slide. Voilà, slide encore. Slide, please. Alors, pour cette campagne, nous avons à peu près emprunté donc, le même schéma qu'en 2019. Slide. Et il y avait encore 6 régions gambiennes qui sont frontalières au Sénégal et 7 régions sénégalaises frontalières à la Gambie. Là, comme vous le voyez, il y a eu l'implication, encore une fois, de tous les acteurs. Ici, nous avons les 2 ministres de la Santé qui se sont fortement engagés et qui ont permis donc la réussite de cette activité de synchronisation entre le Sénégal et la Gambie. Et les résultats étaient plus que probants en matière de distribution, en matière de recensement, etc. Slide. Et ce qu'il faut ajouter ici, c'est que pour cette fois-ci, en 2022, le Sénégal a, au niveau de sa zone frontalière, procédé à la digitalisation donc, de cette campagne, au niveau donc, de sa zone. Alors, quelques bonnes pratiques que nous avons eu à recenser donc, pendant cette campagne par rapport à la collaboration transfrontalière, c'est la supervision conjointe des activités à tous les niveaux. Donc, cette activité s'est menée aussi bien au niveau opérationnel qu'au niveau central. Le niveau central a supervisé donc, cette campagne, donc dans ses dimensions recensement et distribution. Donc, il y a aussi comme autre bonne pratique la digitalisation de la campagne. Mais au Sénégal, elle s'est faite au niveau des districts frontaliers. Il y avait 12 districts frontaliers à la Gambie. Et au niveau de la République de Gambie, ce fut une digitalisation intégrale. Il y a aussi, entre le Sénégal et la Gambie, la mise en place de cette plateforme de visualisation des données de la campagne CU-MILDA. Donc, aussi bien au Sénégal qu'en Gambie, nous avons utilisé le DHSD Tracker et nous avons eu des rencontres, des ateliers donc, pour mettre en place une plateforme de visualisation commune donc, de tout ce qui est ressorti comme données et informations sanitaires de cette campagne de 2022. Diapo. Alors, voilà donc les campagnes donc, que nous avons eues à Diapo, s'il vous plaît. Voilà. Donc, en termes de résultats maintenant de cette collaboration transfrontalière, on s'est rendu compte que la synchronisation entre le Sénégal et la Gambie a permis véritablement d'atteindre de bonnes couvertures. Donc, la totalité des ménages donc, a été atteinte et 95% des personnes étaient couvertes. Donc, il y a également une très bonne couverture géographique des villages, parce qu'avant, il arrivait qu'on oublie des villages tantôt sénégalais, tantôt gambiens, mais cette fois-ci, avec la cartographie précise qui a été opérée, aucun village n'a été oublié dans le processus de recensement et de distribution. Il n'y a pas eu également de doublons constatés lors des activités de distribution. Et aussi, autre résultat assez important, nous avons mieux géré le choix et les préférences des populations. Donc, en termes d'harmonisation des couleurs et des types de milda. Et ce qu'il faut aussi préciser, c'est qu'au niveau de la zone frontalière, nous avons distribué des moustiquaires de type PBO. Donc, ceci aussi est un autre aspect de la synchronisation et de la collaboration transfrontalière entre le Sénégal et la Gambie. Diapo. Voilà, nous allons maintenant passer aux aspects de surveillance, principalement à travers deux mécanismes. Le premier, c'est ce qu'on appelle la PECADOM frontalière. Diapo. Okay. La PECADOM frontalière est une stratégie donc, qui est développée, mise en œuvre avec l'appui de CRS, Catholic Relief Services, donc qui consiste à l'organisation de sorties pendant la période de forte transmission au niveau des villages sénégalais qui sont au niveau de la frontière avec la Gambie, mais à travers 3 districts sanitaires. Donc, des visites à porte sont menées pour un peu avec les dispensateurs de soins à domicile, donc les acteurs communautaires, pour détecter, tester donc des cas de paludisme principalement et accessoirement des cas de diarrhée et d'IRA. Donc, 3 districts frontaliers à la Gambie étaient concernés. Diapo. Alors, en termes toujours par rapport à cette PECADOM frontalière, donc le but c'était un peu de contribuer. Diapo. Donc, c'était de contribuer à l'atteinte de l'objectif d'élimination du paludisme donc, au niveau du Sénégal et de la Gambie, à travers donc, cette lutte transfrontalière. Et les objectifs, et nous les avons atteints, c'était un peu de renforcer cette stratégie de la PECADOM plus au niveau des villages qui étaient frontaliers à la Gambie. Et pour CRS, c'était d'appuyer le programme national de lutte contre le paludisme dans le suivi et la coordination de la mise en œuvre de son plan de lutte transfrontalière. Diapo. Donc, voilà, donc, à travers cette carte, nous avons les districts qui étaient concernés, les postes de santé, diapositive. Donc, 3 districts sanitaires étaient concernés parce que c'était une phase pilote. Il est prévu une extension donc, de cette stratégie pour les années à venir vers une autre république sœur frontalière, à savoir la République de Guinée-Bissau. Diapo. Donc, voilà par rapport à cette donc, frontalière. Diapositive. Voilà, comme vous le voyez ici, les postes de santé concernés sont tout au long de la route. Et les acteurs communautaires faisaient des sorties toutes les semaines pour un peu donc capter tous les cas de paludisme qui étaient tout au long de cette frontière-là. Diapositive. Voilà quelques résultats obtenus par rapport à cette stratégie. Diapositive. Voilà quelques donc, résultats obtenus. On va y passer rapidement. Nous avons ici sur la photo une dispensatrice de soins à deux acteurs communautaires qui est intervenue donc, dans cette stratégie de fort belle manière pour capter les cas de paludisme tout au long de la frontière. Diapo. Le deuxième aspect de la surveillance frontalière, c'est un grand atelier que nous avons organisé avec la République de Gambie pour un peu harmoniser nos méthodes. Donc, ce fut l'occasion d'élaborer des outils harmonisés par rapport aux investigations de cas, n'est-ce pas, dans le cadre de la surveillance pour l'élimination du paludisme. Diapo. Et les objectifs de cette activité, de cet atelier, diapo. Alors, l'objectif principal, c'était de débuter les activités de surveillance et de riposte pour l'élimination. Alors, il y avait plusieurs objectifs spécifiques, donc, à savoir, revenez sur la diapositive, à savoir, c'était l'objectif de partager les procédures opérationnelles normalisées entre les deux pays et de les d'adapter donc ces outils parce que nous avons deux systèmes assez différents entre le Sénégal et la Gambie. Et cet atelier nous a permis un peu d'harmoniser tout cela pour une meilleure intervention future. Diapo. Voilà. Donc, les activités qui sont liées au chantier donc, de la surveillance transfrontalière, c'est la finalisation donc, de ces procédures opérationnelles normalisées, leur validation. Et nous allons aussi procéder au développement d'un programme DHS de tracteurs entre les deux pays, de programmes également sur DHS de tracteurs, formation des formateurs. Nous allons procéder à la configuration de la CIDI, former les agents de santé et ensuite c'est aux documentations des cas et aux enquêtes sur les cas. Diapo. Diapositive. Alors, c'est la dernière diapositive donc, qui présente un peu les perspectives en matière de collaboration transfrontalière. Donc, après les campagnes de distribution de moustiquaires, nous allons probablement synchroniser les campagnes de prévention du paludisme saisonnier, donc la SMC, donc que nous allons probablement synchroniser avec la Gambie. Le seul problème, c'est qu'au Sénégal, nous organisons des campagnes pour les enfants âgés de 3 mois à 10 ans, alors en Gambie, c'est jusqu'à 5 ans. Donc, il faudra discuter sur ces aspects-là d'alignement. Hein? Et on sait aujourd'hui que l'OMS d'aller jusqu'à 15 ans, même par rapport à la SMC. Comme deuxième perspective, nous avons la synchronisation de l'administration de masse des médicaments que nous allons également discuter à Gambie pour un peu synchroniser cette activité. Il y a aussi la surveillance transfrontalière intégrant l'anthropologie, qui est un aspect fondamental, parce qu'avec la circulation de vecteurs, il est important donc, de maîtriser cet aspect de la collaboration transfrontalière. Enfin, nous allons mettre en place des cadres de collaboration transfrontalière avec les autres pays. Nous avons déjà mis en place avec la Guinée-Bissau. Nous allons continuer avec la Mauritanie. Avec la Guinée et le Mali, il y a quelque chose qui avait été mis en place, que nous avons encore renforcé et mieux travaillé sur tous ces aspects-là. Et dans l'élaboration de notre plan d'action, dans le cadre du G7, nous avons fortement donc mis l'accent sur ces aspects de collaboration transfrontalière. Voilà donc la présentation que je voulais partager avec vous et je reste à votre disposition pour les questions qui seront probablement par les participants. Merci beaucoup.
Voilà, merci beaucoup là-dessous. Donc, je pense que nous venons de suivre un autre exemple. Nous venons de suivre. Il y en a qui ont ouvert leur micro. Allô? Oui, c'est bon. Donc, nous venons de suivre cette troisième présentation qui a l'avantage de nous montrer un peu une autre forme de collaboration transfrontalière, toujours dans le cadre de la lutte contre le paludisme. Et ce qu'on a noté, c'est qu'essentiellement, c'est une collaboration directe entre deux pays, donc deux programmes nationaux de lutte contre le paludisme. Et on peut noter aussi que c'est axé essentiellement sur l'harmonisation des interventions dans la bande transfrontalière, sur la synchronisation pour les campagnes de masse et sur l'échange de données et de pratiques. Donc, c'est extrêmement intéressant. Avant de passer à la quatrième et dernière présentation qui va nous être délivrée par, je pense, si je me trompe normalement, par Alexandra. Mais avant de donner la parole à Alexandra, le temps que Lizzie passe la présentation de Alexandra à l'écran, je voudrais juste rappeler à tous ceux qui ont bien voulu nous rejoindre dans ce webinaire. Si vous avez des questions, vous pouvez les mettre dans le QR, comme ça, que ça soit adressé à des speakers ou adressé de façon générale à tous les speakers, vous pouvez les mentionner là-bas. Et par conséquent, je demanderai à tous les speakers de bien noter les questions qui leur sont adressées, que ce soit les questions adressées à Mohamed, les questions adressées à Bongani, ou les questions adressées à Latsou, ou éventuellement les questions qui seront adressées à Alexandra Godon, pour qu'ensuite qu'on puisse vous donner quelques minutes chacun pour apporter quelques réponses. Donc, merci beaucoup. Alexandra, vous êtes en ligne? Alexandra?
Yes. Thank
Hello.
you so much to our moderator and the organizers and other panelists. My name is Alexandra Gordon, and I'm the program director for the Isdell Flowers Cross-Border Malaria Initiative. I'm based at the J.C. Flowers Foundation, which is all the way in New York. And I'll be speaking a little bit about our experience and insights with cross-border collaboration. This presentation will be slightly different from the others, and some of the key points I really want to communicate throughout this presentation is the real importance of having a community presence and involvement and engagement in these cross-border areas. So next slide, please. So first, a little bit more in terms of who we are. The Isdell Flowers Cross-Border Malaria Initiative is committed to malaria elimination through community mobilization along the shared borders of Angola, Mozambique, Namibia, Zambia, and Zimbabwe. So we're working across several countries here, all within the SADC region that Dr. John Chimumbwa had previously spoken about. And we believe strongly that malaria can be eliminated only if those living in areas with malaria have the knowledge, skills, and resources to prevent and treat the disease and to advocate for its elimination. So our work is really focused at the community level and equipping those who are most impacted by malaria to advocate and take action against this disease. And again, these are communities that are located on either sides of the borders that I'll be speaking about. Next slide. So this is a map of where we have implementing partners who are active. Many of these partners are actually attending this webinar now. and they have many more details about the work I'm about to speak of. And so I'll be covering a lot of different countries and regions, and please reach out to me if you would like more specifics, and I'd be happy to connect you with our program managers who are based in Angola, Namibia, Zambia, Zimbabwe, and Mozambique. But you can see here, these dark orange regions are where we are actively working and have partners who are on the ground. We're supporting more than 1,000 community-based volunteers, program managers, field officers who are implementing community-based malaria elimination work in these areas. And of course, working very closely with ministries of health at local and national levels, working closely with the E8 as well. Next slide. And so I wanted to speak a bit about our background with cross-border collaboration. We've been working on this since about 2008, and our work is tied to the launch of the Malaria Elimination 8. At that time, key stakeholders were gathering. The former Minister of Health of Namibia, Dr. Kamwe, Chai was involved, Chris and Neville Isdell, who are our key funders, had discussions about the importance of bilateral collaborations within the E8 region to really carry forward with cross-border collaborations. So I will be speaking about several of those cross-border collaborations, the Trans-Kunene Malaria Initiative, ZAM-ZIM, NAM-ZAM. More recently, we began supporting efforts with ANGO-ZAM, Angola, Zambia, and Zimbabwe and Mozambique. So you'll see there's a lot of information here. I'm just going to give some high-level highlights of all of these collaborations and our experiences with them. In terms of a partner, we are not government, but we do have a strategic role to play in terms of supporting these cross-border initiatives. Some of those roles include the implementation of community-driven control and elimination efforts. So these activities are SBC focused. We're also focused on supporting community-based case management through community health workers and malaria volunteers in these border regions. We also play a role in funding cross-border meetings and convening partners. We also generate our own data. We conduct an annual knowledge, attitudes, and practices survey, and that data is used to guide program decision-making. It's used for advocacy purposes. And so we're also involved in local and national level advocacy. The J.C. Flowers Foundation is also a partner of the FLAME initiative, which stands for Faith Leader Advocacy for Malaria Elimination. So there are faith leaders in these border areas as well who are advocating for more malaria funding and policies. Next slide. So first, I'm going to speak a little bit more about the Trans-Kunene Malaria Initiative. This is one of the initiatives that our teams are most deeply involved in, and it's one of the oldest we're involved in. So this was launched in 2011 by the Angolan and Namibian Ministers of Health. We have two partner organizations, the Anglican Diocese of the Center of South in Angola and the Namibia Anglican Community Development Organization called NACDO, who are involved right on the ground in this region implementing malaria SBC community engagement activities. There are also many other key partners here, some of which are on this call, the E8, Mentor Initiative, for example, CHAI, Ministries of Health, of course, so a long list of partners here. Next slide. And so one of the mechanisms for coordination that we've helped support here are these coordination meetings, which I know other presenters have talked about, but I wanted to highlight here that these aren't just meetings where people come together and talk, but they're really effective platforms to make and review joint work plans, ensure that everyone is accountable to the MOU agreements that were signed. And as partners, we play a role in funding these meetings, in helping coordinate them, sending out those invitations, and really advocating for them to happen. And as I said, these aren't just places where people talk. The action actually happens because of these meetings. So for example, as the result of these meetings, there have been additional and new MOUs that have been proposed that would expand this cross-border collaboration to new regions. There have also been discussions and actions taken based on these meetings to really strengthen case management across the border and both, within these border regions. One example of this is in Namibia. They're conducting active case detection through a triple T team, which is test, track, and treat. And this is a form of active case detection, and the Angolan counterparts were inspired by this method and have started to take up this methodology on the Angolan side of the border in areas with lower malaria incidence. So this type of knowledge exchange and action is what can happen at these meetings. The setting up of WhatsApp communication for data sharing, learning about different trends and behaviors of those who are seeking treatment on both sides of the border. And I'll speak a little bit more about case management realities on the next slide. Next. So just to give some additional context about this region and cross-border treatment seeking, realities are different at each border, but where we're talking about Namibia and Angola here, we see that we have one country, the Angolan side, which has higher malaria incidence compared to Namibia, and also more accessible health facilities on the Namibian side. So what we see is that approximately half of the cases in this border region in Namibia that are diagnosed are actually coming from Angola, and that means certain interventions must take place and coordination has to happen. What we've also learned from this on-the-ground experience is that Angolans pay higher fees when they go and seek treatment in Namibia because they are not Namibians, and because of this, they often may lie about where they're coming from or where they live in order to not pay these fees. So this is the type of insight that's gained by having these on-the-ground teams that can gain this insight directly from communities. And just to provide a bit of an overview of what case management looks like in these areas, as discussed, the Namibia side has a triple T team. This is the NACDO organization, together with the Ministry of Health, involves the nurse and environmental health technician and others who are tracking and following up with each and every case. Each case is notified on WhatsApp. That index case is located, and subsequent follow-up actions take place depending on the situation. So if the household has not received indoor residual spraying recently, they'll receive IRS if there was a positive case in that house. Long-lasting insecticide nets may be provided, larviciding might happen. So this is a really comprehensive package of interventions. On the Angola side, where malaria cases are higher, there's not that same level of active and reactive case detection. However, there are ADECOs, which are a form of community health workers who are active in conducting community education by door-to-door visits and also doing community case management at the local level with the support of our on-the-ground partner, the Anglican Diocese of the Center and South, the Mentor Initiative, the government, and others. Next slide. And so another kind of piece of information or insight into what these collaborations look like are these WhatsApp groups. And so there are various different WhatsApp groups in different regions along this border. So this is just to give a little flavor of what this looks like in practice. In one of the regions, the border with Kunene, Angola, and Omusati and Ohangwena, Namibia, there's an active WhatsApp group that discusses not just malaria issues, but all diseases. It's not a place where each and every malaria case is notified. However, it is used for coordination and subsequent action. So this screenshot on the right just gives you a sense of the type of information that's being communicated here. And this communication and information is used for action. So one example is this method of communication was used to identify a malaria hotspot in a particular region in Angola. And because of that, the Angola and Namibia teams are able to work together and host a static malaria event where that hotspot was, so they could provide additional education. They agreed to train additional volunteers in that area as well. So spurred by information shared on this WhatsApp group and learning about the malaria hotspot, they were able to take action. Next slide. So here's another WhatsApp group, just another example of coordination and data sharing. This is a region that's further east in Kwanda-Kubango, Angola, and Kavango, Namibia. In this case, each and every malaria case is notified. So for example, there is this malaria rapid case notification form that gets filled out within 24 hours of a confirmed case. So for example, if an Angolan is diagnosed in Namibia, this information will be shared back with the Angolan counterparts so that the Angolan side can follow up with that case. There have been challenges with following up with each and every malaria positive case, but the volunteers, the community health workers are doing what they can to do this follow-up. Next slide. So another piece are various pieces of data that we're putting into action with our partners is CAP data. So we conduct an annual survey. I won't go into all the details here, but you'll see a bit about the methodology and an overview of how the survey is done. Each year we survey about 10,000 households that are located in these border areas, so the TKMI region plus others, measuring ITN use, IRS coverage, care-seeking behavior, malaria knowledge, etc. Next slide. And this data is used by the border communities to take action again. So as an example, 2022 survey data revealed that in one of the regions in Namibia, Ohangwena, about 73% of mothers or caregivers reported seeking care for their febrile child that was under 5 within 24 hours. They took this data to local communities so they could conduct an action planning process where they discussed this issue and talked about what they could do to improve the situation, ensure that mothers and caregivers brought their febrile children to a health facility or community health worker immediately. What was decided is that a series of meetings would take place, bringing together caregivers from both the Angolan and Namibian sides of the border to provide more education to them and encourage them to seek prompt treatment. These meetings just happened this past month with more than 200 participants. So here's just a direct example of data being put into action on the border. Next slide. And because we have our local partner organizations on the ground, it's not too difficult to conduct several joint SBC activities each year. One example of one of these activities was a joint training that was done for volunteers and community leaders from both the Angolan and Namibia sides of the border. This means that community leaders from both countries have access to the same information and are sharing the same harmonized information about malaria. There are many benefits to doing this together. The two teams that are on the ground, NACDO and the Diocese of Center and South, have joint activity plans that they create each year, which include activities such as community dialogues, engaging local clergy, training volunteers together, training and meeting with headmen. And so these are all happening as we speak each year along this border area. Next slide. And so some of the challenges that we've heard directly from our partners here are that we have two countries and two border regions with different realities. differences in malaria incidence. We see that Namibia's health system serves Angolans more than Angolan's health system serves Namibians, which can create challenges. Differing policies. For example, IPTP is an intervention in Angola, but not Namibia. Sometimes there are differing policies and timelines in terms of when IRS happens or net campaigns happen. And of course, resource constraints in terms of human resources and funding for activities as well. Next slide. And also at the same time, many lessons learned. We know that synchronized interventions are more accepted by communities when you're hearing the same messages on both sides. There's more credibility. Coordination and cross-border meetings have been an essential part of making this successful. The presence of community health workers in ADECOs conducting community case management has been another key success. And then finally, translation into the local language of all the SBC materials is another critical aspect of this work and something that needs to happen. Next slide. And so now moving on to another border region that we've been actively involved in. This is Nam-Zam. So you can see if the small map on the bottom right is zoomed out and we're looking at the border of Zambia and Namibia, which is quite small, but involves the districts you see in the larger map. This cross-border initiative was established in 2015. And more recently, actually this year, there's been a bit of a shift in focus and a renewed focus on implementing community-based activities and having that be a goal of this initiative. And this was done in recognition that community-based activities are not only less expensive, but also can be more effective when you really have action happening right on the border, led by communities themselves. This cross-border partnership is operating under the SADC agreement that began in 2009.
Excuse me, Alexandra.
Mm-hmm. Yes.
Excuse me, il vous reste encore 2 minutes, s'il vous plaît. Merci.
All right. So I'll go and we can move to the next slide. You can keep going. I'll focus on some of the key points here. Just to say that in this cross-border partnership, we've used the same CAP data to implement activities. So for example, here, actually next slide. So here the CAP data was used. I think this is a great example to actually implement a new activity, which is community-based IRS. So rather than having people come in from outside to conduct indoor residual spraying, community members were actually the sprayers who were involved in the IRS campaign in these areas in Zambia. This idea was shared with Namibian counterparts, and now the Namibian government is looking into conducting community-based IRS. So this is, again, an example where data has been put into action and this exchange between the two countries is happening. Next slide. These are just examples of cross-border data sharing and case management. I think for the sake of time, we'll move ahead. For anyone who's interested, these slides can be shared. Next slide. I want to just make sure I mention our 2 remaining areas here. So the Angola-Zambia work that we've been involved in began in 2018 with a joint training of volunteers and community leaders. This work has continued into this year in 2003, when finally we've seen an MOU signed between the national governments. And here's an example of the importance of local partners and an outside organization, I think, really advocating for this cross-border partnership to happen. And we're seeing those results now as the MOU has been put into place and follow-up meetings are happening this month. Next slide. We think part of this success is due in part to national level attention. There was a big event earlier this year for World Malaria Day, bringing together Angola and Zambia that was broadcast on national television, which was a big success for these teams. Next slide. We also support cross-border work across Zambia and in Zimbabwe. I think an interesting point to highlight here is the way these cross-border committees are set up. There are 3 different clusters across the border, a national level steering committee, and each of these clusters are able to create their own work plans and have done and implemented different activities. For example, identifying vulnerable populations, setting up clinics to serve those vulnerable populations on the border. Next slide, and I only have a couple left, so we'll be wrapping up. And last but not least, our most recent efforts have taken place on the Zimbabwe-Mozambique border. This is through Partners the Methodist Church in Zimbabwe, Harare East District, and we have just begun work in Mozambique on the opposite side. This is on the eastern side of Zimbabwe. Next slide. And so work with this cross-border initiative only began at the end of 2022, but we've already seen a lot of milestones, and we think that's in part due to government ownership and also the presence of our team on the ground, and starting very local at the district level. So rather than having this start from the national level, there's been a lot of local advocacy and work done. There's been a 40-page document that's been made with several action plans, all within just a few months. So this has been really promising. I think I have one more slide just to conclude. So key lessons learned in all of this. Government support and leadership is essential, but just as essential as that community level ownership and engagement. Local organizations, such as the partners that we work with, really play a key role in catalyzing this action, conducting activities, and making this all happen. And having that presence on both sides of the border really can multiply results. We've seen that cross-border agreements that begin locally, so for example, at the district level, have the potential to really generate and demonstrate fast progress, like the example I just gave with Zimbabwe and Mozambique. And we know that gaps in funding exist, but we've seen firsthand that local interventions can take place without funding, particularly when communities are really at the center of this work. So I'm sorry for running over, and thanks so much.
Merci beaucoup, Alexandra. Merci. On s'excuse, on est un peu contraint par le temps pour pouvoir vous donner à vous-même quelques minutes pour répondre à certaines questions. Je voudrais saluer enfin les 4 présentateurs qui ont vu partager leur expérience en matière de gestion transfrontalière de la lutte contre le paludisme. La dernière présentation de Alexandra est extrêmement intéressante parce que ça nous a présenté de multiples collaborations entre pays, entre Zambie, Malawi, Ouganda, Zambie, ainsi de suite. C'est extrêmement intéressant et ça montre qu'en fait, ce sujet est un sujet d'actualité qui mérite d'être approfondi en tout cas, parce que c'est l'avenir de la lutte contre le paludisme. Je pense que nous avons passé en revue fondamentalement 2 modes de collaboration transfrontalière. La collaboration directe entre pays, appuyée par un partenaire technique ou autre, mais aussi il y a une collaboration interpays appuyée par des organisations sous-régionales. C'est le cas de la SADC avec le projet I8. De tous ces exemples-là, ce qui est extrêmement important à retenir, c'est que c'est des moments d'harmonisation entre pays, c'est des moments de synchronisation d'activités, c'est des moments de partage d'expériences, mais aussi c'est d'excellents moments d'harmoniser dans la prise de décision au profit des communautés qui sont dans les bandes frontalières. Mais ce qu'il faut retenir, c'est qu'il y a deux défis essentiels dans cette gestion transfrontalière du paludisme. Le premier défi, c'est qu'il faut nécessairement un accompagnement des partenaires techniques et financiers qui, à mon avis, devront commencer à intégrer
Have to
cette
start to integrate this approach in their support programs. There is a lot of work needs to be doing, but another very essential point is that all of these responses have to be harmonized, but also and particularly we has to be accompanied by
dans une lutte transfrontalière. Donc, je remercie beaucoup nos 4 speakers. Je ne sais pas, Lizzie, si vous n'avez pas des trucs, on va donner la parole à Mohamed. 2 minutes hein, à chaque speaker qui ont pu recenser des questions qui leur sont adressées. Mohamed?
No, thank you.
Thank you.
Okay. Okay. Thank you. Thank you. Please go ahead.
Hi, Rajib. I think if there are any questions in the Q&A aimed at you, feel free to answer them.
No, I think the question we have in the Q&A, I think we've answered them in the Q&A. I don't know if we need to repeat.
Have you written your answers? Okay,
Yes,
that's
yes,
absolutely fine. Hopefully everyone can read through those written answers. There's a couple of other questions if we've got a couple of minutes. So we've got one saying, are there existing cross-border collaboration guidelines which guide the development of the TORs, or do each country groups develop these from scratch in consideration with their context? Don't know if anyone has an answer to that one. I'm not sure quite whose presentation that was specifically aimed at.
Yeah, Bongani here. Yeah, because we were working under the umbrella of the mother body, which is SADC, there has been efforts to actually harmonize these terms of reference. However, we at this point do not have necessarily uniform standards to actually, adapt. However, we do pick up from guidance, be it from WHO and other regions of the world as to how they have actually conducted or kickstarted cross-border committees. However, like I mentioned, there has been efforts, and there was TA to support the development of these guidance as to how countries can best conduct their cross-border or establish their cross-border committees. Over.
Thank you, Bongani. That's great. So we've got another question. I think this one's for Alexandra. So interesting on the border sharing of case notification and follow-up. Do you collect data on the number of cases reported and then those that have been followed up successfully by the respective neighboring region?
Yeah, and so this varies region by region. Some have been more active in collecting this data and tracking down each case, where some have had some disruptions due to COVID and have been less active. The experiences I've heard most about have been in that TKMI region. I can't say for sure if there's a database necessarily for this, but this is something I can check in with my colleagues on as well and get back to you, Hannah. But I would say it depends region to region, and the data exists, but I'm not sure that there's it's readily available for others to see.
Thanks, Alexandra. That's great. I think we've got one for Dr. Latzik. So how did the PECADOM campaign manage to ensure optimal participation of healthcare workers at all of the levels despite scarce resources.
Question adressée à l'ATSUC, je pense. S'il est membre de la PECADOM.
Ah, OK. Voilà, merci beaucoup à Louvimbo pour l'intérêt qu'il porte à la présentation du Sénégal. Alors, pour sa question relative à la PECADOM, il faut dire que cette activité de PECADOM frontalière a été fortement soutenue par un partenaire technique et financier, en l'occurrence Catholic Relief Services, donc qui nous a accompagnés pendant 2 ans à 1 an et demi à mettre en œuvre cette importante stratégie. Donc, la formation des acteurs communautaires, les ratissages qui ont été menés sur la bande frontalière ont été donc effectués grâce donc à l'appui de cette organisation, de Catholic Relief Services, qui nous a beaucoup appuyé dans cette intervention majeure-là. La deuxième question de Nzumbi, c'est par rapport aux points focaux. Je pense que c'est des acteurs essentiels dans la collaboration donc, transfrontalière. Donc, ils sont au début et à la fin du processus. Déjà, à l'élaboration des plans de travail, ils sont là. Mais il faut également dire qu'entre le Sénégal et la Gambie, il y a également un comité technique de suivi qui a été mis en place. Et le comité compte 10 Sénégalais et 10 Gambiens. Hein? Mais c'est principalement les points focaux qui font donc le travail de coordination, n'est-ce pas, entre le Sénégal et la Gambie. Donc, des rencontres régulières sont organisées sous, n'est-ce pas, la coordination de ces points focaux qui échangent constamment, donc pour un peu anticiper sur toutes les activités qui vont être mises de commun accord entre le Sénégal et la Gambie. Merci encore une fois.
Merci beaucoup, Latsouk. Merci. Lizzie, s'il n'y a pas une autre question. Lizzie, vous n'avez pas d'autres questions? On peut passer à la synthèse. Et...
Hi, everyone.
You have another question?
Summarizing now. Got another...
OK. Donc, avant de laisser la parole à Anna, je veux dire merci à tous ceux qui nous ont suivis depuis tout à l'heure. Et je remercie tous les collègues qui ont pu rester connectés et suivre les présentations. Je remercie aussi les speakers pour leur présentation, mais aussi pour leurs réponses très enrichissantes. Je voudrais simplement... Mohamed, oui?
No, please continue, Madame, sir.
Thank you. Donc, on remercie tout le monde, hein, et plus particulièrement Malaria Consortium avec toute son équipe. On remercie aussi Kizou, qui assure le secrétariat du SME avec Katerina pour tout ce qui a été fait en logistique pour l'organisation de ce webinaire. On remercie aussi nos partenaires comme PMI et les autres acteurs. On remercie aussi spécialement la co-lead du comité SPDQ, Arancha et Cadrignon. On remercie Lizzie, Anna, tout ce beau monde qui ont ménagé aucun effort pour l'organisation de ce webinaire. Donc, je vous remercie beaucoup. On essaiera de tirer quelques conclusions des présentations qui seront ultérieurement partagées avec tout le monde. Donc, Lizzie, Anna, je vous laisse la parole. Lizzie?
Thank you, Madine. That's brilliant. Thank you. Yeah, I think we've come to a close. Hannah, I don't know if you have any final comments to make.
No, that's great. Thank you so much to all the participants and to Madoon for your chairing as well. Yeah, it was a great webinar, lots to learn. And if anyone has any questions or any follow-up, then feel free to contact Lizzie or I as well. So thank you.
Thanks, everyone. Have a great day.
Bye-bye.